Thank you very much, Ming, and I'm really delighted to be here. I did my PhD in this building at the start of the 1980s, so a very long time ago, but it's always great to be back here at Birmingham University, which is where I hold my chair. I'm going to talk a little bit about the application of data, particularly in the context of personalised medicine, and then come back at the end of the talk to healthcare science careers, so education and training, because I think there's a conversation we need to have. And I want to start with this slide that really sets out how data can be used to drive our personalised medicine approaches. And that's embracing the 4 Ps of personalised medicine that's recognised wherever you go in the world into something that improves prediction and prevention, provides a much more precise and prompt diagnosis, enables targeted interventions through the use of companion diagnostics to guide treatments and interventions, and embraces a greater participatory role for patients and the public. This is a very hot topic, whether you, last week I was in Stockholm at the EU Presidency Conference on Personalised Medicine. There are many different conferences that I speak to across the world, and that's all because at the centre of personalised medicine is the use of genomic data. But you can see on the right-hand side some of the benefits for patients, but it does, unless we use the data that's generated properly, it really has the potential to drive more inequities in the system. But it does have the opportunity to drive a much more sustainable healthcare system for the future. So you're all going to be critical to this. And we need you to work together with other scientists in the system. So informatics plays a critical role in integrated and personalised patient care and bringing together all these different elements at the centre to drive really patient care. And the one message I'd like to leave you with today is, although it's fantastic to see a conference specifically for the people who work in health and care analytics, it's great to see all the developments around the workforce, but we will only get that patient care if we all work together, and we work together with other specialties. And so we need the IT systems to drive efficiency, whether that's to empower our diagnostic and treatment abilities and through the use of our EPRs. And that's easy to say, not easy to actually do and get to a position, especially if you want to drive a standardised approach across the country. We need to be able to analyse and reduce our health inequalities and enable improvement through the use of analytics, management information and audit capability, and make sure we chase that down vigorously and support clinical decision making through the use of AI, machine learning and other applications. But big data, as in the case of genomics, needs a big infrastructure, and we just have to recognise that and think through what are the solutions nationally or more locally, and what can we do in the most cost-effective way. A critical part of the future will be in bioinformatics, in that analysis of big data, but big data sets that need to be combined, particularly bringing together, for example, genomic, other clinical and diagnostic data, so that we can understand the relationship between genomic change and the phenotypic characterization of patients. We don't have good tools for that yet, but this is starting to evolve. So we will need some novel analytical methods. We'll need scalable solutions, both hardware and software algorithms, to drive our improved turnaround times, increase our genomic data analysis efficiency, because it takes a long time, sometimes 2 days to analyse a single patient. So AI and machine learning will be critical in that. And we have to reduce variability if we want the same outcomes for our patients across the NHS. So last year we published our first ever NHS genomic strategy, and it links with other strategies such as Genome UK and the UK Life Sciences Vision, all of which, as Ben's outlined earlier, really had a data element to them and what should be done as far as data is concerned. I think I was really pleased to see Ben's report that it started to bring it all together, because with some of these separate documents, they all went, although they were heading in the same directions, all with slightly different emphases. A critical part of this was making sure we embed genomics in the NHS. And from NHS England, through our Genomic Medicine Service, we funded, as part of the infrastructure, informatics directors, data science leads, and also bioinformaticians as part of our core infrastructure. We also set out how genomics needed to be at the forefront of the data and digital revolution, not only getting interoperability, data standards, data standardization right, but also on the analytical side, as I've already said, and also that we evolve the service so that we create a learning environment, going back to the point that Ming said towards the end of her talk, because that's how we're going to evolve healthcare in a more rapid way than we've done over time. We will be announcing fairly soon in NHS England our networks of excellence that we're funding for 2 years. There will be an AI and machine learning network of excellence, all about bringing together academic units in this country to really think through some of the problems of analysing big genomic data sets. Why is this important? We're moving towards more personalisation. That's what the personalised agenda is about. This is just a paper taken out of, a diagram taken out of a Nature paper that really just sets out what we're trying to do from genomics is molecularly profiling patients, understanding what important prognostic markers they may have, markers of prediction of drug sensitivity and resistance, or of adverse drug events, and then tailor a medicine. In lung cancer, we have 8 licensed medicines for lung cancer. They all require the identification of a different genomic mutation and a different phenotypic profile before a patient can access that information, often at the start of that journey. But you can see what that quote is at the bottom here about we have to do this in a systematic way and not just make sure that all that expertise is holed up in a small number of centres. I want to just tell you a story about when we get this right, but some of the challenges of analysis. This is the story of Reuben, the story that Amanda Pritchard told last week in Westminster Abbey when she sort of addressed the 75th anniversary celebration. From NHS England funds a rapid whole genome sequencing service led out of the Royal Devon and Exeter Hospital for acutely unwell children and babies that are likely to have a specific gene defect called a monogenic disorder. And that's actually contributing to them being in NICU, PICU units. You can see through starting this service, we now have got a diagnostic yield in these patients of 41%. So nearly half the patients have a genetic cause for why they're in ITUs or HTU or NICUs or PICUs. This requires all of this to get to a diagnosis, but look at the size of the data that is being handled in terms of the file size. Look at the number of variants per sample that needs to be analysed for just one patient. And this is being led by bioinformatics teams. At the moment, they don't bring the phenotypic data together. It's more a conversation between clinicians. But think about what we could do if we could bring that together. But this just highlights, just in one application, in one patient, exactly what it means. And then these are the different variant effects that can actually happen. So it requires annotation and filtration, but it requires significant informatics and data challenges to bring all this together. This was Ruben. Ruben got a diagnosis of a particular type of deficiency. But look at what his father said. They thought he was not going to survive. And now he's a healthy baby, a healthy toddler. And he recently met Amanda Pritchard. And he was able to have personalised treatments and interventions. This is what the work that you do can help in terms of patients and the outcomes, not just for the individual, but for their families. The work that we're doing in genomics is also supported by data and digital developments, not just in the infrastructure and the interoperability, but in data standardization, improving access and functionality, in creating a unified genomic record that could be used over the course of a lifetime, given we can reanalyze genomic data time and time again. And thinking through to those TREs that Ben talked about, that Ming mentioned, is how we create a vendor-neutral archive to make sure data could be accessed but available for research and development, to support diagnostic discovery through analysis of genomic variants that we don't know what they mean at the moment, but then fed back in to the health system. We also need to be better at analysing the data to understand how we're progressing, how we're also addressing issues like equity, inequality, but it does mean bringing a whole bunch of data together, both having it available, but our ability to analyse it is critical. So I want to just move on in a different direction now into sort of the role that I play as also as head of profession for healthcare science across the NHS and all other associated bodies. These are all the disciplines that we recognise within the healthcare science workforce. And you can see in the bottom right here that we recognise clinical informatics, whether it's bioinformatics in genomics, in clinical informatics in health, or in clinical scientific computing in the physics and engineering. Across all of these specialties, though, they generate huge amounts of data. Over 1 billion diagnostic tests are generated by this workforce every year. A huge amount of data. They are all producers of data, but also analysers of data. And I think we need to think together about how we consider what is required for both the data generation and the data analytic approach for the future. So this is the career framework that I introduced early in 2010. It's a standardised approach to all those specialties for education, training, assessment and regulation, right from the red box, which is around healthcare science assistants and associates, often supported by apprenticeships, through to a practitioner level, into a clinical scientist level where people are recruited as graduates, many come in with PhDs, into a consultant clinical scientist where people undergo a 3-year higher scientific specialist training program, similar to doctors before they go into their consultant roles. You can see at the bottom right there the number of people that we've got accessing our scientist training program in clinical bioinformatics, in genomics, in physics, and also in health. Relatively small numbers, but we have got the funding to put more in. But there are also some higher specialist trainees who are coming through, but tiny numbers. We can do more, and we can create a very attractive career framework with salaries that equate to medical staff at the very top. And that's what we need to do, keep our analysts in the NHS and not actually going out into other sectors. So we can do more, and I commit here now to work with Ming and Peter to see what else we can do to bring this to a reality. And you can see this is just an example of a step into career in bioinformatics across all of those different areas, which I'm not going to go through. There's also linked to what was the Topple review that looked at the future of technology in changing healthcare. A clinical data science programme was established. It's delivered by the University of Manchester in conjunction with the National School for Healthcare Science. And this is designed really to apply data science for people who aren't data scientists, analysts, data engineers, or any of those. But it's just to say, this is the overview of the PG Cert programme. This is progressing, and I think in conjunction with what we need to do with our very specialist resource, we also need to think about the 1.3 million people employed in the NHS and how we get them better able to use data, use the outputs of what you produce, but also ask the right questions in the beginning that often is the ones that send us all round in circles before we can get to the answer. So I want to finish now to say we're most definitely at the tipping point. This is the change that the future of the NHS is going to need. We're going to need to use data in a very different way, but data, and this was on one of Ming's slides, to make sure that we can create individual maps of individual patients that are accessing our healthcare system, bringing together all of their data. This is what will really enable us to personalise care, to change the dynamic of the NHS from what is an illness-related service into one that's much more about earlier diagnosis, prediction and prevention. Thank you very much.